Hi, everyone. My name is Lene Mudd. I'm a program officer at the National Center for Complementary and Integrative Health. We fund a lot of research on complementary and integrative health interventions for a range of outcomes, but pain management is one of our biggest portfolios.
And so right now there are a lot of workforce efforts happening. Yep, I'm short, so let's try and make this a little bit easier. So there are a lot of efforts happening at NIH and specifically within the HEAL initiative to increase the workforce efforts for pain. So what we want to briefly go over is talk to you a little bit about some of these one-pagers that we have created, and we'll leave up here, about some of the active HEAL workforce efforts that are available both for later stage investigators, but also novice investigators through the HEAL initiative. So please consider applying to those different resources. And then we also have a lot of great NIH resources about training and how to submit grants. There are different blogs about resources of how-to, so please feel free to come by and pick up these one-pagers. But HEAL recently has put a lot of time and effort into both the clinical pain workforce as well as overall pain workforce. So we're going to highlight two today. One is going to be the National K-12, which is funded here by the University of Michigan, so we're very excited. And then the other one is the Purpose Network, so we're going to give really high overviews. Please feel free to reach out to us afterwards if you have any questions about what we talk about here today, or if you have any questions about anything in these slides, or in these handouts.
Great. So, it's actually a really great time to be an early career researcher interested in pain because there is a lot of opportunity. But one thing that we noticed as program staff at the NIH working on HEAL was that there wasn't a ton of people in the pipeline to become clinical pain researchers. And that's something that we are trying to work on with several different opportunities to better support that career path. And so that's part of what went into the formation of this National K-12 program to really establish a nationwide clinical mentoring program, recognizing that there's a lot of people at environments other than University of Michigan that don't have all these wonderful resources at their fingertips. And wouldn't it be great if there was a way to really provide resources and mentoring to individuals across the country and really create cohorts of individuals with similar research interests that could lean on one another and on mentors spread out across the country, as well as mentors from individuals with lived experience. And so that's really where the K-12 came from. And the goal is to select and train a diverse pool of clinical pain researchers that will expand this workforce and also to develop better guidelines for the mentoring and career development aspects. So we're very excited about this K-12 program launching and really hopeful that this will help to support the scholars successfully transitioning to the next level of their career, and that this program will really collaborate with the Purpose Network that Laura is going to talk about. So Laura is the program director for this program. I am the program scientist for this program. I'm also a training officer at NCCIH, so I interact with early career individuals and mid-career individuals all the time. And we're really excited that coming up, you're going to hear from the first three appointed scholars to this program. Dr. Ma, Dr. McGill, and Dr. Mueller are going to present their research. And we're just really excited to see where they'll go with this support. So, Laura?
Great. And then,
Yep.
Again, short person here. Okay, really quickly, the other big initiative that we funded recently is called the Purpose Network. So this is positively uniting researchers of pain to opine, synthesize, and engage. And the reason why we funded this network is to really connect pain researchers across the continuum of pain. So connecting preclinical, translational, and clinical researchers in the same platform to be able to share research ideas, to be able to collaborate with each other. So there's an online platform, so if you're interested in joining, you can either scan or join the go to the website. And so what we're trying to do on this network is trying to bring together funding announcements that are out there, might be of interest to people, job postings, webinars that are either happening that are being created by the Purpose Network, or pulling them together by the different organizations, the pain organizations, as well as HEAL is putting out a lot of webinars. We're also trying to really enable collaborative working spaces there in private capacity, so you can meet people from across the country, across career stages, to work on grant applications together. So if you have any questions about either of these networks, please let us know. And I am the program director also for the Purpose Network. Delaney Torres, who's also at the National Institute of Neurological Disorders and Stroke, is the project scientist. So if you have any questions about this network, please let us know. Purpose is being run by Neuro Innovations, and the PI is Jacob Coverstone, so also please feel free to reach out to him. And if there are any really quick questions, we're happy to take them, but we are around, so please feel free just to reach out to us over the course of the next day. Thank you.
Any questions for Laura or Lene? We have time if anyone has any questions. Well, you can also just reach out to them individually.
Yes.
They're very responsive.
Yes.
Okay.
Thank you, everyone.
Yeah. Yeah. So our first trainee is Eoin Kelleher. Eoin, I think on the other side of the pond they would call you an anesthetist. Here we would call you an anesthesiologist. Eoin is finishing his PhD. He's been doing his PhD with Irene Tracy. I think he might have the distinction of being the last of Irene's pain trainees, as she now is the Vice Chancellor of Oxford. And something that I didn't know about Eoin until I visited Oxford recently is he's quite a cartoonist. He actually draws cartoons. There might be some, if you see any cartoons in his slide deck, he probably drew them. So, Eoin?
Thank you, Dan. So everything is just PowerPoint clip art, unfortunately. Although we did vote in Ireland to change our name to anesthesiologist about 4 years ago, so we've branched off from the UK in that regard. One of our many attempts to differentiate ourselves from our neighbour on the other pond to us. So as I said, I'm Eoin Kelleher. I'm an anesthesiologist from Ireland. I'm doing a PhD on chronic pain with Irene Tracy's group, and Anushka Soni is my other mentor. And I'm just going to present some work I carried out with members of Dan's group, Chelsea, Dorna, and Andrew, looking at how the burden of comorbid symptoms or comorbid non-pain symptoms predicts subsequent nociplastic pain in UK Biobank. So I won't have a lengthy introduction on what nociplastic pain is, because I think that was really well covered in yesterday's session, which was fantastic, particularly around the importance of the non-pain aspects. But what we don't really know very well is whether these symptoms precede or predict nociplastic pain itself. And so what we wanted to do is to see whether 3 comorbid non-pain symptoms, sleep, mood, and cognitive disturbance, can precede nociplastic pain onset in a cohort of middle-aged adults. So we had 3 objectives. So first, determine if these comorbid symptoms precede chronic nociplastic but not non-nociplastic pain. To examine if there's a dose-response relationship between the burden of these symptoms and nociplastic pain severity. And also to examine if there's a relationship between these symptoms and the onset of chronic overlapping pain conditions. And this is to try and look at different aspects of nociplastic pain, again, to make us more confident in the findings. So in terms of methods, we looked at UK Biobanks. So just as a brief overview for anyone who's not familiar with it, this is a large population-based cohort study of 500,000 UK adults recruited between 2006 and 2010, and they've been followed prospectively ever since. After about 10 years, participants were asked to complete an online detailed pain questionnaire, which a third of participants completed. And in addition, we have linked primary care records, so the GP records for about 2/3 of the sample as well. For this study, we looked at everyone who completed the pain questionnaire and who had no pain at baseline. So this was no recent pain or chronic pain. So people were asked at baseline if they have any pain. These are the people who said no. So this is about as pain-free as you can get in UK Biobank. Our exposure of interest was the burden of 3 comorbid symptoms: mood, sleep, and cognitive disturbance. And then we also took into account some sociodemographic and lifestyle factors which could potentially confound any association we may observe. Our main outcome was looking at nociplastic pain. So because there's no agreed upon measure of nociplastic pain, we use the fibromyalgia survey criteria as a continuous measure of fibromyalgia-ness, because this is probably the prototypical example of nociplastic pain. And then for our first analysis, to rule out any centralized element, we also took the DN4, which is a measure of neuropathic-like pain, to try and isolate out people with a really non-centralized pain phenotype. And then, as I mentioned, in addition, we also looked at chronic overlapping pain conditions from their GP records. So these are the results. So 70,000 participants had no pain at baseline, and these were followed up for an average of 10 years. They were 55% female, and just as has been well described for UK Biobank, it isn't actually representative of the UK population. It's much whiter, it's much healthier, it's much wealthier. But that would also make you less likely to find an association in some ways. And at baseline, 20% had sleep problems, about a quarter had problems with mood, and we took the bottom quartile of cognitive function as kind of a sensitive measure of cognitive dysfunction. When looking at nociplastic pain at follow-up, we just stratified it based on whether they have chronic pain at follow-up. You can see that both DN4 as a measure of neuropathic or centralized pain and fibromyalgia scores are higher amongst those with chronic pain at follow-up. And then 1 in 8 were diagnosed with the chronic overlapping pain condition over the subsequent 10 years. So this is for our first objective, where we looked at the association between comorbid symptoms and the type of chronic pain at follow-up. So to do this, we divided participants into 5 categories based on their pain status at follow-up after 10 years. We looked at whether they have chronic pain, yes or no, so that's CP plus or minus, and whether they have a neuropathic, nociplastic-like pain at follow-up, as is NP plus or NP minus. So on this figure here on the x-axis, you've got the number of comorbid symptoms, so whether they've got no symptoms or whether they've got all the symptoms, and on the y-axis, just the proportion who fall into each category. And what you can see is that as the number of comorbid symptoms is greater at baseline, they're more likely to have chronic nociplastic or neuropathic pain, but they're not more likely to have chronic pain without these features, which is the teal box in the middle. So this suggests that the burden of baseline comorbid symptoms is associated with greater odds of developing chronic pain with so-called centralized features or nociplastic-like pain, but not chronic pain without these centralized features. And when we did multinomial regression analysis, this wasn't affected by adjustment for lifestyle and sociodemographic factors. So then our second objective was to look at the association between these symptoms and nociplastic pain severity. Again, we used the fibromyalgia survey criteria for a continuous measure of fibromyalgia, where higher scores probably reflect a more severe nociplastic pain phenotype compared to lower scores. And in the top left panel there, you see that on the y-axis, the number of comorbid symptoms. I'm sorry, the writing is very small and I can barely read it myself. But in the bottom here, you've got people with all 3 comorbid symptoms, and then the top is 2 and then 1. As the number of comorbid symptoms is increased, you're more likely to have higher fibromyalgia scores at follow-up. We broke it down then between the widespread pain index, which is the top right, and the symptom severity score, which is the bottom left, which are the 2 subcomponents of the fibromyalgia survey criteria, and the relationship is similar for both, indicating that this is driven just by the symptom severity aspect of fibromyalgia, which captures a lot of the non-pain aspects, or just the widespread pain index, which is the number of pain sites. And then we also looked at whether people met fibromyalgia criteria on the fibromyalgia survey criteria. And again, people with more comorbid symptoms at baseline were much more likely to meet criteria at follow-up. So this suggested that there may be a dose-response relationship between the number of comorbid symptoms and subsequent nociplastic pain severity after 10 years follow-up, which is present for both the widespread pain index and the symptom severity score. And again, this wasn't really affected by adjusting for sociodemographic and lifestyle factors. So finally, we wanted to look at whether people with more comorbid symptoms are more likely to be diagnosed with a chronic overlapping pain condition over the subsequent 10 years. So what you can see in this Kaplan-Meier survival curve is on the x-axis follow-up, and then the y-axis proportion being diagnosed with a COPC. And the blue dotted line is people with 2 or more comorbid symptoms, and these were more likely to be diagnosed with a COPC over follow-up compared to those with no comorbid symptoms at baseline. So again, this suggests that people with more comorbid symptoms are more likely to be diagnosed with a COPC, more likely to be diagnosed quicker, or not quicker, but earlier, and that this wasn't, when we did Cox proportional hazards regression, this wasn't affected by adjusting for sociodemographic and lifestyle factors. So in summary, there has been very little previous literature on the longitudinal connection between these comorbid symptoms, mood, sleep, and cognitive disturbance, and future nociplastic pain. So this addresses that predictor research gap. So in our prospective study of pain-free adults, those with more comorbid symptoms were more likely to develop chronic nociplastic pain, but interestingly, not chronic non-nociplastic pain, which suggests this may be an opportunity for early intervention in mitigating the burden of chronic nociplastic pain in the population. However, as Ted kind of alluded to, we don't really understand why this is happening, and we do need further well-designed, large neuroimaging studies to help us understand the underlying mechanisms, and therapeutic studies to help us understand what types of treatments might work to prevent nociplastic pain. So thank you very much for your attention. I'm very happy to take any questions if we have time.
Questions for Eoin?
stunned
Great.
in silence.
It was very clear.
Thank you.
So the first of our K-12 appointees will be Jessica Ma. Jessica is a palliative care physician. Let me pull up at Duke.
Okay, let me just make sure this works. Okay, so hi everyone, I'm Jessica. I'm in the internal medicine department as well as also at the VA, and I'll be presenting a little bit more about my research on complexities in pain management in advanced kidney disease. So what we're going to talk about today a little bit more is a little bit about the background of pain in kidney disease, some of my preliminary data that's been supported by the VA Pain and Opioid Core funding, as well as my next steps within the K-12 program. So chronic pain in older adults with advanced chronic kidney disease, something to consider, especially for those with kidney disease, is that they have poor long-term prognosis and quality of life. So for those with advanced kidney disease, particularly, especially for those who don't pursue dialysis, have about a median life expectancy of about 3 years. So they have years, but not decades of life. Half of these patients have chronic pain, and about a quarter of them are on opioid medications. However, for these patients, treatment is associated with adverse events, and treatment options are also limited. Advanced kidney disease patients can't take non-steroidal anti-inflammatories. In addition to that, opioid medications, in addition to gabapentinoid medications, are all associated with increased risk of hospitalization and death. And the benefits of pain management in this population is really unclear, especially when they have poor long-term prognoses. At the same time, national guidelines exclude palliative care patients. There's not really any guidance in terms of how we should start taking care of these patients. And therefore, clinician pain management practices vary widely. So a little bit more about my preliminary data. And in my study, funded by the VA Pain and Opioid Pilot Funding, we specifically wanted to look at risks of significant opioid adverse events associated with the severity of kidney disease, and especially with opioids with increased metabolites in kidney disease, so those that aren't determined safe. And I'll explain these two a little bit further. So chronic kidney disease is labeled in 5 stages, with the 6th being end-stage renal disease. So for most of the people in this room, unless you already know that you have some kidney disease, you'll be categorized in stage 1. For clinicians, we don't really start thinking about adjusting medications for patients until they're in at least CKD 3. And then from there, there's CKD 4, 5, and then in terms of this study, we determined those who are on dialysis as end-stage renal disease. In addition to this, thinking about how are opioids actually metabolized in kidney disease. This is an oversimplification of the pharmacokinetic data, but I'll try to I wanted to kind of portray this in a way that's easy to understand. So specifically, in the studies that we currently have, codeine, hydrocodone, and morphine are determined unsafe because they have increased metabolites. They have been known to be associated with increased sedation, especially when used in advanced kidney disease. Hydromorphone and oxycodone, however, are on the potentially safe. People actually, they have been published guidelines and are recommendations that say that you can use these in the advanced kidney disease population, with oxycodone being a maybe because some published recommendations actually say don't use it, others say it's okay to use. And the last being buprenorphine, fentanyl, and methadone. And so we'll kind of split these up into those that are inappropriate and those that are moderately safe to safe. So how do we go about the study? We used a retrospective sample of veterans that were over the age of 18 from 2010 to 2017, and those who are on long-term opioids, so more than 90 consecutive days of opioids in the prior 180 days. In addition to this, we really wanted to try to find those who had chronic kidney disease compared to those with acute kidney injury. So we wanted to make sure that at least 2 creatinine values that were 90 days apart really had levels that were at least CKD 3 or below. And then lastly, we wanted to also make sure those who are actually utilizing the VA system. So at least 2 visits, outpatient visits in the past year, or at least 1 VA inpatient admission prior to entry into the cohort. So we started with approximately 400,000 veterans that were on long-term opioids, and then narrowed to about 178,000 that had creatinine values over the past year, and those that utilized the VA. We then merged in the United States renal data system to identify those who were on dialysis. So that was approximately 1,100 patients. And then determine the CKD stage based on the last EGFR available prior to their cohort entry. So those were then labeled the no CKD group to the CKD 3, 4, and 5. So we'll show some preliminary data because the analysis is still ongoing. So the mean age of this group was 62 years old, predominantly male, Caucasian, as well as non-Hispanic. We used a modified Charlson Comorbidity Index for this group because Charlson Comorbidity Index also includes kidney disease. So for this, we took the kidney disease out, and in this, there is a median of 1 to an interquartile range of 1 to 3 comorbidities. In addition, the starting daily dose of the opioids was approximately 23 milligrams of oral morphine equivalents, and this was actually very similar across all of the groups. So there wasn't an actual decrease, or clinicians weren't actually decreasing their dose when starting someone with advanced kidney disease. The majority were prescribed hydrocodone, oxycodone, and codeine, and there was a large minority that were also co-prescribed benzodiazepine, so 20% throughout all of the groups as well. So when we're looking at this a little bit further, and what we're finding is that there aren't really any changes in clinician prescribing patterns when you look at patients without CKD and those that had advancing stages. They're all fairly similar. The recommended medications in kidney disease is very rarely prescribed. Mostly, they're all moderately safe, and majority is unfortunately inappropriately prescribed. Morphine, being the one that's well known for most clinicians to not prescribe, was still being prescribed for those with end-stage renal disease, and even those that were supposed to be prescribed more, like hydromorphone, was minimally increased in this population. So when I started to think about and look at this data a little bit further, I started to think of what happens in the patient and clinician encounter, and how do clinicians then end up deciding on what medication treatments to offer to patients. And so some of my next steps within my K-12 program is thinking through the pain communication and decision-making between the clinician as well as the patient. And so some of my K-12 specific aims will look at examining the persons with lived experiences and the clinicians, including nephrologists, palliative care clinicians, geriatricians, primary care clinicians, because primary care actually prescribes the most opioids in this population as well, to really think about what are the challenges and needs when we approach decision-making through interviews, in addition to then looking and identifying phenotypes of persons with lived experiences, preferences, and their choice questions when they're thinking about pain management in their decision-making. And I want to thank my mentoring team, my primary mentor, Dr. Hayden Bosworth, in addition to Dr. Chadwick and Lynn Madalana, the K-12 mentors, and my co-mentors, Dr. Cox, Dr. Bowling, Dr. Lorenz, and Dr. Steinhauser. And I also want to thank both of these programs and want to open this time for any questions as well.
Questions for Jessica?
Yes.
Do you know whether most of these patients get their prescriptions from the VA, if there are barriers in terms of what might be authorized by payers that contribute to the opioid rate?
So all of these patients were being prescribed from the VA. We didn't use any data from Medicare for this population. With the VA, you actually can use, we don't have a lot of limitations on opioid choice. While we do have to do some prior authorizations for long-acting opioids, it's not as likely for short-acting, which is what we primarily studied here.
You know, most of the prescriptions go stop and they had like a pre-checked thing that they just gave to everybody, or whether they had any thought into it.
So these shouldn't have been post-op patients because they were long-term opioid prescriptions, so they were being prescribed 90 days of opioids when they started and were entered into this cohort.
Any other questions? Great, thanks so much. Our next speaker is Lakeya McGill. Lakeya is from Johns Hopkins, and she is a pain psychologist that studies sickle cell disease.
Okay. Hi, everyone. As you said, my name is Lakeya McGill, and I'm a postdoctoral fellow at Johns Hopkins. And today I'll be talking about the impact of discrimination on pain-related outcomes in adults with sickle cell disease. I do not have any financial disclosures or conflicts of interest in relation to this presentation. So my worldview, which is shaped by my background and my identity, influences everything that I do, including my research, my clinical practice, my advocacy. And so I want to start off by talking about who I am. As you heard, I'm a pain psychologist, and I was trained in both clinical psychology as well as community psychology. I also identify as a Black, cisgender woman with an invisible disability. I was raised in a working class family in the rural South, so specifically, as you see in this red star right here, a rural town of about 7,000 people that's 2 hours from both Nashville and Memphis. I also am a first-generation college graduate. And so all these things really shape the questions that I ask, how I interpret my data, all these types of things. In our current sociopolitical context, there has been an increased focus on the impact of systemic racism and discrimination in our society. As a Black woman, this has been very encouraging, something I've been very excited to see. As a pain psychologist, though, I often find myself thinking, what do I do now? What do I do now knowing that systemic immediate change is unlikely and that change is going to continue to take time? What do I do now as I'm meeting with a young Black patient who's reporting difficulty dealing with racism, pain, and mood disturbance? And it was this question that led to my current research and my focus on establishing equitable pain care for all, as well as developing personalized, culturally adapted, and appropriate interventions and care. So sickle cell disease is a genetic blood disorder that primarily affects Black people in the United States. The disease is characterized by both acute and chronic pain, and then unfortunately, as you all heard from our patient, person with lived experience, in healthcare settings, people with sickle cell disease often experience discrimination and stigma, such as them being characterized or perceived as individuals who may be drug-seeking or malingering. And what we know is that racism-based discrimination in healthcare settings is associated with worse pain. However, the mechanisms that link this racism-based discrimination and pain is less known. Theories suggest that both depressive and insomnia symptoms, which we've heard quite a bit about in the last 2 days, are potential mechanisms that may link both racism and pain, particularly as depressive and insomnia symptoms are common in the context of chronic pain, including for adults with sickle cell disease. However, no previous studies have actually examined depressive and insomnia symptoms as these mechanisms in this patient population. And so the purpose of one of my studies was to examine whether depressive and insomnia symptoms sequentially mediate the association between racism-based discrimination in healthcare settings and clinical pain in a sample of adults with sickle cell disease, and we hypothesized that there would be significant mediation. This study included secondary data analysis. It was 68 Black adults with sickle cell disease who were recruited from the Sickle Cell Center for Adults at Johns Hopkins University. To be eligible for the study, individuals needed to be 18 years or older, diagnosed with a sickle cell hemoglobinopathy, on a stable dose of medication over the past month, as well as reported no vaso-occlusion episode in the past 3 weeks. We use reliable and valid measures, as well as we assess for both baseline pain severity interference using the brief pain inventory, as well as we assess daily diary pain severity and interference over the past 3 months. We also control for various socio-demographic variables such as age and pain catastrophizing. So we conducted 4 models. In the first model, which included baseline pain severity, the results were not significant. However, for the next 3 models, they were. And so what we found was that racism-based discrimination in healthcare settings was associated with baseline pain interference. However, when we included depressive and insomnia symptoms into the model, the relationship between racism-based discrimination and baseline pain interference was no longer significant, which suggests that mediation occurred. The results were the same for both daily diary pain severity as well as daily diary pain interference. And so the implications that can be drawn from this are that discrimination in healthcare settings contributes to depressive symptoms, which then acts on pain through sleep disturbance. So a mediation occurs. Poor sleep, which is a strong predictor of pain outcomes, may manifest secondary to depressive symptoms in sickle cell disease. And this is important because, as we know, the relationship between depressive symptoms and sleep is complex and bidirectional. And so this was just one step in trying to better understand that. Also, there's an important need for systemic and structural changes to eliminate discrimination and stigma in healthcare settings. And then also, behavioral interventions may help reduce the impact of discrimination on pain by us targeting mood and sleep disturbance. The implications of this study, of course, must be considered in the complex of the limitations, such as us having a small sample size. It was cross-sectional. We only collected data at a single clinic, and that clinic was also a sickle cell specialty clinic. For next stages and next steps, which is some of the work that I currently have ongoing, as well as a part of my K-12 project, would be to examine the impact of intersecting experiences of discrimination, so thinking beyond discrimination based off racism to things such as ableism, which is very prevalent in the healthcare system, as well as just the general society, and something that impacts individuals with sickle cell disease and various chronic pain conditions. We also want to think about how are people internalizing and processing these experiences of discrimination, and then how that then leads to them having negative attitudes about themselves, as well as even what it means to have sickle cell disease or another chronic pain condition. Also want to be thinking about discrimination as well as other social determinants of health outside of the healthcare system. These things are not isolated to just what's happening in healthcare. So all this is just an initial step towards an important goal of us developing this personalized, culturally adapted behavioral and multi-level. So we want to get to multi-level interventions. And for me, this is just a piece of the pie of my larger research program, which is promoting equitable pain care. And as a part of that, we'll continue to conduct research that's examining the impact of sociocultural, environmental, and psychological and behavioral factors on pain-related outcomes, including adults with sickle cell disease. I want to identify individuals and groups who are at the greatest risk of these pain-related outcomes, and that's maybe related to factors such as social determinants of health that may put them at a greater risk, as well as it's important to think about protective factors as well. So people's resiliency, maybe their spirituality, their social support, and then as, again, just developing these culturally adapted, appropriate, and multi-level interventions. I would like to thank my research support that I've received, as well as my mentors and collaborators, as well as the Hill, K-12, the various people who are involved. Thank you.
Questions for Lakeya? Jason?
Can you say more about the ICP-18 and kind of what it measures, and does it vary by like accordance between the provider's race and the patient's race?
So I'm not sure about so the question was, what is the relationship in terms of the concordance between the patient and the provider?
And what does the ICP-18 ask about, and how does it capture those?
Yes, so what is the interpersonal processes of care, IPC, questionnaire assessed? So that's a really great question. It's actually a major limitation of this study, as it's just a 2-item measure that's getting at people's experience of discrimination and potential unfair treatment in a healthcare setting. That's actually going to be a huge part of my K-12, is that I want to use these more common, reliable, highly reliable, multi-item measures to get at people's experience of discrimination, both in healthcare and outside. Because actually, although sickle cell disease is a highly racialized condition, the research looking specifically at discrimination is very limited, as well as we haven't even looked at some of the common measures like everyday experiences of discrimination or major experiences of discrimination in this population. So that's a great question. It's a limitation that we use that item.
Anne?
Yeah, kind of along those lines, should we as clinicians be thinking about discrimination really as something that belongs in ACEs as we're moving forward? And do you think you could look at those path models and put any ACE at the beginning?
Great question. So the question is, how does this racism-based discrimination relate to people's general experiences of trauma, including during their childhood and adolescence? And yes, so, well, here's how I'll say it. So in terms of the theories, for example, the social stress theory is going to conceptualize racism-based discrimination as a social stressor, similar to if someone's experiencing various traumas. Similarly, I also was just recently on a publication where we conceptualized discrimination as racism-based trauma. And so we are starting to think about the racism actually being traumatic and having similar symptoms to what we see for PTSD. Great question.
Any more questions? Yeah, one more. Diva?
You might not have an answer to this, but for the protective factors that you were talking about, would, just like your healthcare provider validating that even though they might not be able to fix like the whole healthcare climate and all the problems with that, like in their one visit, acknowledging that it is an issue that is like racism within the medical system, would that be like a mediating protective force? I saw one paper where acknowledging the fact that there was racism by the healthcare provider was like potentially mediated. Is that something that...
Okay, so your question is, how does the role of the healthcare provider's attitude and behaviors, such as them having compassion and validating the patient, how that may influence the outcomes, including the patient's pain and various symptoms? So I'm not really familiar with that literature. I would say that it likely has not been much research that's looked at some of the things like the concordance between the sickle cell patient and the provider, or the specific interactions. Honestly, just getting at the research is limited in sickle, so there's such a need for a lot more, substantially more. But that's a great question.
Great, thanks so much. Our last K-12 trainee is Bridget Mueller. She's from Mount Sinai in New York. She's a neurologist that studies headache. Oops, sorry.
It's okay.
My bad. Oh, you got it.
No worries.
That was a test. That was like...
We have 8 more minutes until snack time. All right. Okay, so my name is Bridget Mueller. I'm a neurologist at Mount Sinai, and today I'm going to talk to you about chronic migraine and the role of the autonomic nervous system in chronification. So I don't have any conflicts of interest to disclose, financial, but I do want to say that I was a bench scientist for many years before going to medical school, and I studied stress systems, so I am likely a little biased. And so in the clinic, I see patients with migraine, and migraine can be classified as either episodic or chronic. It's episodic if there's fewer than 15 headache days per month, and classified as chronic if it's 15 or more. And what's important and what patients will tell you is that in the beginning, typically, migraine starts off
vary with clear paroxysmal events. There's a beginning and there's an end, and then there's a return to neurological baseline in between, right? And then as the migraines get more frequent, this neurological baseline starts to shift, right? And this is when the non-painful symptoms that we've heard a lot about start to become prevalent. It's fatigue, it's gastrointestinal symptoms, it's orthostatic intolerance, and it's mood issues. And often it's these issues that make a patient come in to see me, right? It's, yes, pain is debilitating, but it's these symptoms that make patients unable to work, unable to take care of their kids. So one of the key questions that I'm asking in this K-12 is, what are the processes that are involved in this transition from an episodic to a chronic pain disorder? And so migraine is a stressful experience, right? It's stressful to have a migraine. It's stressful to think about having one and not be sure when you're going to have one. And so our autonomic nervous system is our stress response system. It controls how blood pressure changes, heart rate, gastrointestinal motility. And so our hypothesis is that the repeated activation of these central and peripheral components of the autonomic nervous system over time causes dysregulation of this system and a shift in its own baseline, which then could potentially contribute to some of these non-painful symptoms that occur with chronic migraine. And so one way that we can assess the autonomic nervous system is through measurement of autonomic reflexes. And we're lucky at Mount Sinai in that we have an autonomic lab. There's very few of them in the country. We can measure things like the blood pressure and the heart rate response when a patient moves from lying flat to sitting up with a tilt table, or their sympathetic efferents that are responsible for sweating. And through sort of a global assessment of these reflexes, we come up with a composite autonomic severity score. And so we looked at patients who were referred to our center for testing who had migraine. And it's very common that patients who have migraine have orthostatic symptoms, so we get a lot of referrals of patients with migraine. And so we retrospectively looked to see, do patients with chronic migraine differ in their autonomic reflex activity? Do they have different reflexes compared to those with episodic migraine? And I was actually shocked at this data. And this qualifies as autonomic neuropathy in patients who are by and large young and healthy, right? And they have a CAS score of 3 or more. And so we also look to see what's the prevalence of symptoms that patients are reporting to their neurologist, the non-painful symptoms. And we looked at 3. We looked at fatigue, we looked at orthostatic intolerance, and we looked at cognitive impairment. And patients with higher CAS scores were more likely to report more of these non-painful symptoms of migraine. And so in addition to the global measure of autonomic function, we also looked at a specific reflex, the baroreflex. And this acts to maintain our systemic blood pressure, and it also plays a really important role in cerebral perfusion. And this was particularly important and interesting to us because, one, migraineurs have a lot of orthostatic intolerance. Two, reduced BRS is associated with heightened pain sensitivity, and it's present in patients with fibromyalgia and other nociplastic pain disorders. And that during stress, in order to optimize our fight or flight response, this reflex is suppressed. And so it seemed to be a potential biomarker for chronic migraine. And so we looked at patients with episodic and chronic migraine and found that a really large percentage, over 50% of our patients with chronic migraine had reduced baroreflex sensitivity. And again, we saw that reduced baroreflex sensitivity was correlated with the burden of non-painful symptoms in patients with chronic migraine. And so I wanted to pause here and think about, there's been a lot of those circle diagrams over the last day, right? What comes first? Is this the chicken or the egg? What's the significance of a reduced baroreflex sensitivity? And autonomic dysfunction in patients with migraine? Is it all just correlation? Are we just looking at, we're stressed when we have pain, and so our autonomic reflexes are suppressed? And is there a role for maybe intervention here at the level of the vagus nerve or these autonomic reflexes? And so through a collaboration with our colleagues in psychiatry, we looked at the neurometabolites in the hippocampus of patients with psychosis, which is another episodic stressful disorder. And we saw that the baroreflex sensitivity correlated with neurometabolites that are associated with things like myoinositol, which is a marker for gliosis, excitatory activity, higher glutamine and glutamate levels, and dysmyelination choline. So it seems to suggest that the baroreflex sensitivity is actually, could be important in regulating central signaling. And so this led to the hypothesis in my K-12 that I'm hoping to examine, which is that alterations of autonomic reflexes are really important in the mechanism through which migraine is causing changes to our central autonomic network. And so specifically, the first of my aims is looking at the phenotype of patients with migraine. We'll use autonomic function tests as well as ultra-high field MRI, although after Ted's talk, I'm having second thoughts about the MRI. And then after the extensive phenotyping, we'll follow these patients for 12 months and see who transforms out of the episodic patients and who reverts with treatment. And do any of these stress endophenotypes predict who's going to revert and who will chronify. And eventually, I would, in a larger, longer study, look to see, are there any specific endophenotypes that are responsive to topiramate versus a CGRP antagonist? We have lots of medications as migraine physicians, but we don't know, what medication is going to work best for the patient who walks through your door. And that's a problem because it takes a long time then to treat someone and to get them feeling better, and that can compromise your therapeutic relationship. And then finally, aim 3, which is in a small subset of patients, look to see, are these reflexes reversible? Meaning are they plastic? Or if I have a low baroreflex, does that just mean that I'm more likely to get chronic migraine? Or is this baroreflex low because of all the migraine I have, and once I treat the migraine, the baroreflex sensitivity goes back up? And that's an unanswered question in the field. So I want to thank my amazing mentor, Dr. Robinson Papp, who's here in the audience. She directs our lab, and we have a fantastic lab at Sinai. I also want to thank the wonderful K-12 mentoring committee, and we're only a month in, but I've already received such incredible feedback that's really changed my protocol. Chris Feasley is my mentor with lived experience, and she gave me some great feedback on my protocol before I submitted it to the IRB. So it's a really wonderful program, and I'm grateful to be a part of it. Thank you. Yes?
Are you aware of any treatments that could directly change baroreflex sensitivity?
So we have vagal nerve stimulators. So we have GammaCore, which is an acute treatment for migraine that affects the vagus nerve and increases its sensitivity. We also have Parasim, which is not approved in the United States, but it's used in Europe, and that's one that I'm involved in a clinical trial at Mount Sinai to look to see if constant non-invasive vagal nerve stimulation can change baroreflex. Not in patients with migraine, but this is patients with long COVID. Yes?
You really should talk with your colleagues about ketamine, because there is something in there. Ketamine is absolutely improving autonomic sensitivity, and it would be really cool if we could make the correlation with the baroreceptors. I mean, that's helping people walk back that migraine progression that you were
Right.
You have a lot of people there. You really should do something.
Yeah, I would love to do that. We have a pretty large, several clinical trials at Sinai using ketamine, but it's right now only for patients with depression. So I do encourage my patients with depression and migraine to go enroll in those trials. And anecdotally, they say it's really helpful.
Maybe we'll have to talk.
Yes. Yes.
Can I talk to you after all this? Because you're literally what I want to be. I'm about to go to med school.
Oh, of course. Of course. I love my job. I love my job. And it was a long road and certainly not straight. I mean, I went to medical school later in life and after a PhD and years at the bench, but it was, it's been a good decision. Although at times I've questioned it. Yeah.
Yeah. One more question?
Yeah.
Well, thank you for everything.
Of course.
The biggest nerve is having a bit of a heyday.
Yes, it is.
Some of that more scientifically oriented, some of it less. And I just wondered if, as someone who is studying this, do you have any comments or thoughts on what you're seeing in the more popular literature and how that makes sense?
Well, I think that it captures people's imagination and is an appealing type of therapy for lots of people who don't want to take a medicine. Right? The idea of holding something up to your throat or wearing something in your ear as a way to reverse a lot of these issues is of course very enticing for people, and so I think that generates a lot of excitement as something. Now, it's going to have to be part of this multi-leveled treatment approach, right? It's Megan and I were talking at lunch today that I think it's going to be an important component of a treatment plan, but it's not going to be, there's no magic bullet for chronic pain, right? But I think addressing dysregulation in the autonomic nervous system has to be there, and it rarely is. But I think it needs to be something that's in place as we add on our CGRP antagonists, right? But if someone's blood pressure is 180 over 110 and they're walking around, they're not going to feel good. So, yes.
Great, thanks so much. We're going to take a break now and we'll reconvene at 2:15 for the next session.